And thank you very much for the invitation. It's great to be in Rome. Wonderful city. So the title gives you something of an introduction to what I'm planning to talk about, which is obviously submacular hemorrhage due to wet AMD. What I'm going to try and do is think about how we manage it. These are my conflicts of interest. In terms of an overview of the talk, I want to think about the background. There'll be some bits that are sort of targeted more towards the residents, people in training, others that are sort of actively working in vitreoretinal surgery. So I want to look at some of the basic elements to submacular hemorrhage, think about how often or how seldom it occurs, think about how it can present in various ways, talk through the natural history of the disease, and then think about the management options. And that's really where I'm going to focus the talk, is to think about how we manage this disease, because the evidence is not clear. So with that in mind, what I'll try and do is bring together a synthesis of the literature that exists, and then we'll talk through the RCTs. There aren't many, but we'll go through those one by one. And at the end of all that, we'll try and put it together and think about, how should we manage our patients as best we can. So many of you will be very familiar with wet AMD. It's an extremely common disease, as you're aware. That depends on which data you look at, but if you look at many studies, they would suggest at least that it's certainly the most common cause of blind registration. But in fact, some of the data suggests that AMD, wet and dry together, cause more blindness than all other eye diseases put together. Hugely important in terms of blind registrations. We're obviously very familiar with the disease and that it can have some small hemorrhages. So hemorrhages is part of the clinical presentation of wet AMD. But what we're talking about here is something very different. This is these significant, large submacular hemorrhages that present, I would say, quite separately to the small amount of hemorrhage that you would see just as a barometer of disease activity normally. So how common, or I would say probably how uncommon, are submacular hemorrhages due to wet AMD? There's different data out there, but I think probably two of the best studies were population-based studies, both just, I think, by coincidence, based in Scotland. It depends which definition you take. If you say the submacular hemorrhage has to be at least 1 disc diameter, and that's your definition of submacular hemorrhages we're talking about today, then a population-based study suggests an incidence of 24 people per million per year, which is not a lot. If you increase that threshold to being 2 disc diameters, so that's a larger hemorrhage, a smaller patient population, the numbers we're looking at are perhaps about 15 people per million per year. And if you look at that in terms of numbers, that would meet the European Commission's definition of a rare disease. So obviously wet AMD is very common. These large submacular hemorrhages are very rare. So how do these patients present? Well, it varies. The mean presenting visual acuity is very poor. They often present with often quite catastrophic loss of vision. Because AMD can often be a bilateral disease, it can be in their better seeing eye. If you look at numbers, the mean presenting acuity is about 6/60. So that's obviously poor. It's often the first manifestation of wet AMD, and this is something that can catch, I would say, the trainees out, because you're looking for the patient to already have wet AMD, but maybe they don't know they've got wet AMD the first time they present. Is with these very large submacular hemorrhages. You remember that idiopathic polypoidal choroidal vasculopathy can present with hemorrhages in all the retinal layers, and that's very much true of wet AMD as well. So in fact, 20% of the patients with these large submacular hemorrhages are associated with polyps. So the polyps are overrepresented in the patients with large submacular hemorrhages. Some very useful clues to the disease are drusen, which you can sometimes see in the other eye. So you may not see terribly much in the affected eye because of the drusen are obscured by the hemorrhage. But a good clue is to look for signs of wet AMD or AMD in the fellow eye, because the fellow eye will often have some drusen there as well. So can we get that door closed if that's possible, actually? In terms of the clinical manifestation, it varies. Sometimes it's relatively small in this context, or the hemorrhages can sometimes be absolutely enormous. And they vary quite a lot in terms of the way they present. But this is a sort of, I feel like a textbook presentation. And it's very important when you have a look at this to have a think about where the hemorrhage is in relation to the retina. Is it under the neuroretina or is it under the RPE? And that can vary in terms of the way that the disease unfolds, and it can also influence how you treat the patients. Sometimes if the hemorrhage has been there for a longer period of time, you get this separation. It's a bit like sort of an ESR. You can see the plasma floating on the top under gravity, and you see that quite clearly in this image. I would say you don't normally see things like this, but it's a very textbook presentation in this situation. And then the other distinction, as I say, is to pull out whether it's sub-RPE or sub-neuroretinal. And I think this figure does show that reasonably well. You can see the very distinct border at the edge of the RPE. It gives you a very sharp definition, and the hemorrhage under the RPE is often a lot darker because it's underneath the pigment. Whereas the sub-neuroretinal hemorrhage tends to be a less distinct border, shown as the yellow arrow there, and it's often much brighter, fresher looking blood. So do try and make that distinction, because it does, particularly if you're operating, it's very important to make the distinction in terms of surgical planning. So if you look at OCT, the OCT can actually be extremely difficult to interpret sometimes. Obviously, I've tried to pull out an illustrative case, but sometimes it can be very hard to pick up the definitions of the different retinal layers, because the hemorrhage is often all the way through the layers of the retina and neuroretina and RPE. But here's an easy one to look at. What we're showing there in the astrocytes is sub-neuroretinal hemorrhage. So you see that on the image far right. It's fairly clearly underneath the neuroretina. It's above the RPE. You can see the RPE very clearly. It's an easy one, easy call. In this case, it isn't always. Hemorrhage traditionally would be described as being hypo-intense, but actually that's not always the case. It can be hyper or hypo-intense. And in fact, you see that quite nicely in the picture there. You can see some of the subretinal hemorrhage appears white, some of it appears dark. So it could be fluid, it could be hemorrhage, but not necessarily, the clue is not always there in terms of whether it's hyper or hypo-intense. You see next to that a large pigment epithelial detachment. The PEDs are quite a helpful clue when you're looking for either polyps or wet AMD. So if we flip to the next image here, what you can see there is the sub-RPE hemorrhage. Much darker on the photograph, and it's clearly defined in terms of the anatomy there with that OCT image. But you do want to do that. And the reason will come clear as we go through the talk, but as you can imagine, if you inject into the RPE, you will cause an RPE tear. So if you're intervening, you want to know exactly where the RPE elevations are. Also, of course, if you think about it, they're not going to respond to subretinal TPA, because the TPA may be sequestered away from the sub-RPE blood. So you've got to think about what can we treat. And interestingly, what you'll sometimes see, if there's a big RPE elevation at the fovea, which I get the impression that happens disproportionately in a large number of patients, that can actually protect the fovea. The RPE sits there and pushes the subneuroretinal hemorrhage out to the side. So it's not uncommon. You can see a big PED and actually very little neuroretinal hemorrhage underneath that, because it's all being displaced by the RPE. And actually, and you don't necessarily need to treat those patients as you would otherwise. So angiography is often not especially helpful. Doesn't mean you shouldn't do it, but what I would suggest is think about when you should do it, because the textbooks would say, well, ICG can look through, it's long wavelength light, it can see through the hemorrhage, but in reality, you still get masking from the hemorrhage, not as much as you get from the fluorescein angiogram. There is truth in that, but oftentimes you won't see anything very much, even with ICG. ICG is particularly important in this condition because, as I say, polyps are overrepresented, and the ICG is the best way of picking those up. So I would usually want to do an ICG alongside your fluorescein angiogram if you're doing imaging. But my suggestion would be to think about when's the best time to do it. What you might choose to do is to wait. So get the patient presents, you get treated with whatever you're going to treat them with, and maybe give it a bit of time for the hemorrhage to clear before you go ahead and do your angiogram. You may find out more if you do it a bit later. So what's the natural history of this disease? And the answer is very simple. These patients do extremely badly. It's a dreadful disease. It is a blinding disease. And actually there have been some problems getting hold of TPA. And it's worth keeping that in mind. Sometimes there are some hospitals, the pharmacists have been saying you can't have TPA. There's a limited global supply at the minute that has to be preserved for patients who've got stroke. And you can say, well, actually, this is a stroke, and it's a terribly blinding disease. If we do nothing, these patients will do dreadfully. So sadly, that the natural history, probably the best natural history study comes from the control arm of the submacular surgery trial. A decent number of patients, 140 patients in a quality clinical trial, and only 11% achieved 660 or better. So if you do nothing, these patients do really, really badly. The question then is, why is that? Why do these patients do so badly? Well, there's probably a number of reasons for that. Some of this is based on animal experiments. But iron is toxic. We know that. There's something called the Fenton reaction. The iron creates free radicals, which are very damaging to the neuroretina. There's mechanical fibrin contraction. If you imagine all this fibrin contracting down, shearing off the heads of the photoreceptors and causing mechanical damage as well. So definitely there's damage from the fibrin itself. There's also reduced oxygen and nutrient flux. The path length, the RP at the minute, you've got the normal anatomy, you've got the choroid right next to the outer retina. It's a very short path length for getting oxygen out of the choroid into the neuroretinal cells, which of course, remember, are hugely metabolic, the most sort of active demand of oxygen in the entire body. So if you increase that path length of diffusion with maybe 120, 200 microns of hemorrhage, that will affect the oxygenation, so that retina become very ischemic very quickly, and you won't be able to remove the waste products as quickly as well. So it's not surprising that blood is toxic. So if there was one take-home message from the talk today, it would be act quickly. Treat this like you would maybe a macular off-retinal detachment. It's not something to sit on and refer routinely for a vitreoretinal opinion in 2 weeks' time. So the main treatment that people have brought up, actually, get rid of that. Stop, we're losing the thing there, aren't we? The main treatment that people are offering is tissue plasminogen activator, TPA. You'll remember from medical school days that it's a large glycoprotein, 70 kilodaltons. It's a big molecule. It's about the same size as some of the biologics we're treating at the minute. You remember it activates plasminogen to plasmin, and it's very, very effective at breaking down fibrin clots. Anyone who's used it in the anterior chamber for fibrin will be aware of just how quickly and how effective it works. Obviously, it's not licensed for use in the treatment of submacular clots. It's used for stroke, for very large pulmonary embolus, and for ischemic myocardial infarction, but it's unlicensed in use with the eye. So if you're treating a patient with TPA, you need to let them know it's an unlicensed off-label treatment. It's not unlicensed, it's off-label. So in terms of looking at the standard of care, what we did is try and look at practice surveys and look at the literature and try and work out what our colleagues are doing. How is it being treated? And it depends on which meeting you go to. If you go to a surgical retina meeting, you would think that everybody has surgery. If you went to a medical retina meeting, you would think very few people have surgery. So different crowds have different approaches, and you see that in terms of the practice surveys. But generally speaking, there are three main strategies. The first strategy is intravitreal TPA and gas. Virtually everybody, I think, would give anti-VEGF now. The literature in the past had some treatment without it, but generally speaking, I would put as a default, everybody has anti-VEGF therapy. And then what do you have on top of that? And the treatments are intravitreal treatment alone, so just put in gas, put in TPA, or do you use surgery to deliver subretinal TPA and a fuller bubble of gas through fluid gas air exchange? So if you look at the best outcomes, so this is, I'm going to go through the RCTs individually, but this is just a summary of the non-RCT case series data. So it's, take it all with a pinch of salt, but in a sense, maybe it's the best we've got in terms of collating the information. So if we look at intravitreal gas, TPA, and anti-VEGF, that gave the best final acuity. So if you remember back to the natural history studies we looked at, where the mean visual acuity was about 660, these patients do much better than that. So on average, they're about 20 over 66. The next best outcome, I think, perhaps slightly surprisingly, was anti-VEGF monotherapy. So just hitting them hard with anti-VEGF monotherapy, these patients do much better than the natural history, because the natural history studies were obviously undertaken before anti-VEGF was available. And so the next best outcome, as I say, at about 20 over 26 is anti-VEGF monotherapy. And then the worst final outcome is with surgery. But the paradox is it also has the greatest visual improvement. And what that tells us is that most likely that surgery is being used for the patients who are presenting with the biggest hemorrhages and the worst vision. So what we're seeing there is a selection bias. The patients are doing very well if you look at their baseline, even though they're doing not so well in terms of their final visual acuity. And I think that's generally the perception amongst vitreoretinal surgeons, is that if it's a big hemorrhage, they are probably more inclined to treat with surgery because they feel that the intravitreal therapy may not be enough. But we're going to question that with the data. So I'm going to move to the first of the 3 RCTs, and they roughly double in size each time we move from one study to the next. So the first is a very small study by Jan van Meurs and his team. Only 24 patients with submacular hemorrhage. The hemorrhage had to be there up to 14 days, but no longer. And all the studies have that in common, or thereabouts. And he randomized the patients to 2 active treatment arms. One was intravitreal TPA and gas and bevacizumab, and the other was vitrectomy, subretinal TPA, and gas and bevacizumab. So surgery versus intravitreal treatment. The main outcome was reduction in submacular hemorrhage at 6 weeks, and he found very little difference between the 2 groups. It's a large study, but both treatments seem to be effective at clearing up the hemorrhage. But obviously this is a pilot study, it's no more than that, but it's of interest. So next up was our own TAPIS study. This was a randomized factorial feasibility trial undertaken at King's College Hospital. That's where I work along with some colleagues who collaborated from Maidstone, Sunderland and Hull. We recruited a total of 56 patients. Likewise, we took submacular hemorrhage up to about 14 days, but no longer. And the primary outcome was visual acuity at 3 months. Now, it's interesting to think, when is the best primary outcome for this trial? Usually speaking, we're used to seeing studies with outcomes at 1 year. We chose 3 months because the disease itself will be evolving, and we thought we might get a better handle on how the drugs are working if we do it for a shorter follow-up. But in fact, we've debated that for our subsequent studies and actually reverted to a 1-year outcome. So although we report out to 12 months, we chose our primary outcome at 3 months, but to be debated. So factorial studies are quite a nifty way of, if you like, kind of getting a larger study for the price of a small one. You may be very familiar with the trial design, but I'll go through it just in case you're not. So all the patients on this trial had ranibizumab, and that's based on the synthesis of the literature that we showed earlier on. Is actually, you probably need to give that as a bare minimum. So everybody got ranibizumab treatment. And then they were randomized into different groups. So there was sham treatment, there was TPA alone, there was TPA plus gas, and there was gas alone. So you have 4 different arms, and then you combine them in different ways in terms of your analysis. So the first comparison looks at no gas. So you take patients with sham or TPA, and you basically try to isolate the effect of having no gas at all. And you compare that to gas on its own or gas with TPA. And of course, the TPAs balance each other out. So you can try and isolate the effect of the gas on its own. The second analysis, factorial analysis, looks at no TPA versus TPA. And again, you get the patients contribute to different groups in this way. So you then have 34 patients in the no TPA group compared to 22 patients in the TPA group. So this is cutting straight to the results. And what we found was, I think, quite unexpected. We imagine that you need the TPA to dissolve that clot, and then you need the gas to massage that out of the way. But in fact, that's not what we found. This is only a small study, so you wouldn't expect to get a significant result. But as I say, the surprise was we did. That the TPA resulted in a significantly better vision. And the reason it's significant is there's such a big difference between the 2 groups. So 16 letters, despite the fact that everybody's had anti-VEGF therapy. So that suggested it's the TPA that's having a really big effect. The difference for the gas group was only 5 letters. And that might still be, statistically significant in a much larger trial, but it's a much smaller magnitude of difference. So it's curious that actually the gas didn't seem to be having anything like as much effect as the TPA. And I think that's believable. I remember this, and I hate to use anecdote when we're trying to drill down on the evidence, but I had one patient of mine, we had to get permission to use the TPA because it was off license. And I saw them at the end of the week. Thought, well, I'll get the anti-VEGF on board and I'll get the gas on board. And then I got permission to give them the TPA. And I saw them on the Monday morning, really nothing had changed, nothing had changed. And then we got the permission came through on the Monday morning to put the TPA in. We put the TPA in and bang, the hemorrhage cleared really dramatically. So I think as you use it for stroke, for heart attack, I think the TPA is somehow having a really positive effect. You don't necessarily need to have the gas. I mean, we can't say that from this data. We can't say the gas isn't useful, but it seems that you can get a benefit just from the TPA on its own. So important caveats, it's a small study, but it does suggest that it's possible that the benefit's being driven by TPA and not by gas. So the next trial was the STAR study. This is done in France. It's a very good study, actually. It's a multi-center, randomized superiority trial. You can't really mask these trials because everybody can see the bubble of gas inside the eye. They know if they've had a vitrectomy. So you can mask the observers, but you can't obviously mask the patient or the operating surgeon. So we're now up to 90 patients in this trial. They all had wet AMD, and the submacular hemorrhage had to be there for up to 14 days. They're randomized 1-to-1 to either surgery or intravitreal therapy. Surgery involved vitrectomy up to 0.5 mils, which equated to 50 micrograms. Just if anyone's taking notes and you're going to give this treatment when you get back to work, it's micrograms, not milligrams, so 50 micrograms of TPA and 20% SF6. The intravitreal group also had 50 micrograms of TPA and 100% SF6, 0.3 mils. This sounds like a very simple procedure, but if you haven't done it, actually, it's surprisingly time-consuming and difficult. And all you need to do is put it in, so the injection is very straightforward, but the pressure goes very, very high, so you need to do a repeated AC paracentesis. And what happens is you take a bit of aqueous out of the anterior chamber obviously flattens, and then there's no space to go back into the anterior chamber to take more fluid. You've got to wait for the anterior chamber to refill, and then you go back and take another round of fluid out of the anterior chamber. You don't want to take it out of the vitreous, obviously, because you can cause a retinal break potentially. So you've got to allow a lot of time. I think it's probably easier to do it in theatre, to be honest, because you can use the microscope at high magnification to work out where you are in the anterior chamber. You don't have to. But take your time with this, because otherwise you'll find that as the AC collapses, and if you're not very experienced in going with this, you'll end up snagging the iris, causing iris hemorrhage and iris drag out of the wound from the needle. So I personally take an insulin syringe, bend the needle, take the plunger out, and then go in. I don't go in sort of straight through. I go in at a bit of an angle, and I'm watching very closely that I'm in the same plane as the iris, but anterior to with the bevel facing up, because it's very, very easy to catch the iris with this. And as they take your time, and then you've got to check that the central retinal artery is patent at the end of this, so you're checking it the whole way through, because the pressure can go up very, very high. And you need to get them back and keep a close watching, because as the gas bubble expands over the next day or two or three, can end up with, again, very, very high pressure. So you need to keep a really close watch on these patients, even though it's the simpler treatment versus vitrectomy. Coming back to the trial, both groups had 3 days of posture, upright, face forward at 45 degrees. They all had ranibizumab at the end of the intervention, and then loading dose, 3 doses, and then as required thereafter with follow-up out to 6 months. So looking at the primary outcome, they went for visual acuity at 3 months, and then fairly standard secondary outcomes, visual acuity change at 6 months, the visual function questionnaire, NEI VFQ-25, number of anti-VEGF injections, and the recurrence and complications, so safety. So they had 87% follow-up to 3 months, which is enough statistically, but actually that's quite a big fallout. And these patients often have significant comorbidity. They're often quite unwell. They often have ischemic heart disease or whatever it might be, but they're often quite a moribund, frail group of patients. So you've got to, when you design these trials, take into account that there may be a fair degree of attrition. And this is the primary outcome. So this is their main result, but I want to talk through it because it looks like one thing, but actually I think it says another. So the intravitreal group gained 16.4 letters, and the surgery group gained 16.8 letters. So you would look at that and say that basically intravitreal therapy is the same as surgery, and it's obviously a lot easier to do. So that would suggest we shouldn't be doing surgery for this. But keep in mind the design was it was a superiority trial. It's not a trial that was designed to show equivalence. It was designed to show surgery was better, and it didn't show that. So it doesn't give you a result on that. Safety was pretty good. About 27% of patients had an ocular adverse event. There were retinal detachments in the surgical group, 2 during surgery, but that doesn't matter so much because it's dealt with at the time of surgery, and then 2 post-operatively. So a relatively high retinal detachment rate in a trial of this size. And there are also more recurrent submacular hemorrhages in the surgery group, but I don't think we read too much into that because you can get retinal detachments from intravitreal therapy as well. It could just be coincidence. These are small numbers, but maybe there's a signal there. But the key message here is that the trial did not show surgery to be superior to intravitreal therapy. And to come back to my point, it doesn't show equivalence. And the best way to explain that statistically is to look at the confidence interval of the difference between groups. So if you look at, you say with 95% certainty, what difference could there be between the 2 arms? And that runs everything from almost about minus 15 letters almost up to plus 11 letters. And that's because the trial is small. It's not big enough to have a small confidence interval. So what that tells us, it could be that surgery is 10 letters better, which would be clinically meaningful. It could be that intravitreal therapy is 10 letters worse. I mean, well, it could be either way around because you don't have statistical significance on that. So we don't have a result effectively from that trial, even though it was a good trial. So next up is the Tiger study. This is one that we did ourselves in London. It's ongoing at the minute. The aim was to look at the safety and efficacy of vitrectomy, subretinal TPE and gas. With approximately 65 centres, we're hoping to get as many as that. It's a non-commercial trial, randomised superiority trial. It's observer masked, active control, and it's a surgical trial, obviously. I won't go through that. That's just a layout of the trial, which is fairly standard, except to say it's a large, sort of relatively complex trial with all the precautions in place, like trial steering committees, data monitoring committees, reading centre, and such like. We had 2.2 million funding from Euretina, which was a sort of international competition. People bid to run the trial. That sounds like a lot of money. It really isn't. To run a trial on this size, if this was industry, there'd be another 0 on the back of that. 2.2 million is a tight budget to deliver a trial of this size for a rare disease. We've got available ILEA free, so we can standardise across the arms, although actually we haven't called on that yet. In terms of eligibility, we're looking for patients that submacular hemorrhage involves fovea. We take patients who've got wet AMD, polyps, or RAP. The hemorrhage has to be at least a disc diameter across. And the visual acuity, we have a wide range here, everything from counsel fingers up to 70 letters. Now, some surgeons might say, well, if their vision's 70 letters, I don't want to do a vitrectomy. Or if it's a really big hemorrhage, I don't want to have them randomized to just anti-VEGF control. But the surgeons can make that call themselves, and then we will describe the patient population and we'll generalize to that same population as well. So we give the investigators a fairly wide range of scope in terms of visual acuity and function. We exclude those where the hemorrhage has been there for more than 15 days and high myopes for obvious reasons. We're aiming to recruit a total of 210 patients, which, as I say, is difficult for a rare disease. And they're randomized 1-to-1 either to surgery or to the control arm. So surgery involves a phaco, if the patient and the surgeon want to, vitrectomy, induce a PVD, inject TPA. We mix we take alteplase. You can also use cath flow as well. It's a cheaper alternative if you can't get actylase. That's also less wasteful. It's only 2 milligrams in a vial. Diluted up with the diluent that comes with the injection, and then diluted again to give it an isosmolar solution with saline to end up with 100 micrograms per mil. We use a very fine bore cannula, so usually 38 gauge or less, inject to cover the whole of the submacular hemorrhage. I'll show you a video of this in a minute. And you can do that either manually with your assistant injecting yourself, holding the cannula subretinally, or there is Med1 make one that you can use automatically with a foot control pedal, which is quite nice. Do fluid air exchange. We're using 20% SF6. We're using aflibercept as our anti-VEGF therapy. We position patients on the back for 15 minutes, then they go upright, face forward for 5 days, sleeping on the operated cheek to pillow for 10 days. But the surgeons can vary that. If the hemorrhage was right off to one side, you might choose a slightly different posture if that was, that wasn't a good posture for the patient to front on.
Here's a couple of examples of the subretinal injection procedure itself. The first is a moderate-sized submacular hemorrhage. The camera is advanced to the subretinal hemorrhage and held on the surface of the retina, and then the foot pedal depressed. This will result in subretinal injection fairly easily in most cases. The injection should be continued until a bleb of DPA surrounds the submacular clot, as shown. Following peripheral retinal check, an air fluid is performed. It should be noted that the aflibercept injection should begin after the air fluid injection, but before the gas exchange.
So I'm going to cut through the next one actually, because although we started late, I'm sure the organiser will want to get back on time if we can. In terms of the control, anti-VEGF therapy, all patients get aflibercept monthly for 3 months and then 2 monthly mandated injections. And a take-home message would be, if you're going to treat these patients with just anti-VEGF monotherapy, or in fact, no matter what, hit them hard with anti-VEGF therapy. Don't use a sort of a light as required type dosing. Give them lots of anti-VEGF because they do rebleed, and you want to encourage the resolution of the hemorrhage. So go hard with your anti-VEGF therapy. Primary outcome is a 10-letter gain at 12 months, but we're looking at mean visual acuity as well over 12 months. Reading speed, because the scotoma can obviously affect the reading speed, so we also look at the visual field. We do visual function questionnaires, and then we have reading center look for areas of atrophy and fibrosis, because it might be that if you shrink down the hemorrhage, you shrink down the subsequent scarring and disciform lesions that might form otherwise. Fairly standard safety outcome reporting. A lot of people to thank. These are the centres that are up and running at the minute. So lots of sites involved, 106 patients so far. But as you see, it's a rare disease, and lots of those centres have only got 1 or 2 or 3 patients recruited. But we have many more still to join. These sites are all been set up, so we're moving forward. But it has been a challenge. The challenges that the trials have faced, I think any one of these on their own is a big challenge. But we've had to deal with a lot of obstacles. Brexit has been a nightmare in terms of running clinical trials from the UK. I won't sit on the fence in terms of my view on Brexit. It's been a disaster from a scientific point of view. TPA supply, as I mentioned, has been a big issue globally. And as I say, you often have to go to fight your corner to get the TPA versus people who wanted to keep it for stroke. And a good way through that is to go for cath flow, because the cath flow isn't used for stroke. It's not a life-threatening disorder, and you can use that just as easily. Those of you involved in clinical trials will know that there's been a massive change in terms of the EU regulation, in terms of clinical trials. The new system has come through, the new CETUS is the new portal. Huge change. Actually, for many months, nothing happened, even with the commercial trials, because nobody quite knew how the new system would work, and there were lots of teething problems. And then a very small extra thing called COVID pandemic, which some of you may have heard of. So we had a lot to deal with this trial. But we're making progress, as I say. We're more than halfway through. Lots of people to thank. So for time, I won't read through all of them, but my co-applicants, and in particular, I'm also ready to say Lisa Ramazotto, who's, if you haven't guessed from the name, and my research fellow, Chan, who's done a lot of work on the trial. So just to come to the last slide in terms of the key points to take home. Submacular hemorrhage, the natural history is terrible. These patients do very badly. You should probably do something for all of them. The management approach varies, so there is no right or wrong with this. We don't have the final answer yet. I would say, though, use anti-VEGF therapy as a minimum and get the treatment on board quickly. TAPA suggests that TPA may be driving the visual benefit. The STAR trial didn't show superior visual acuity with surgery over anti-VEGF therapy, but it doesn't establish equivalence. And the TIGER trial asks if surgery is superior to anti-VEGF monotherapy and is about halfway through at the minute. So thanks very much if there's any questions.